Thank you so much. I'm on the National Advisory Committee on COVID in Israel and turned positive just 4 days ago. So nobody is actually immune, even though I'm vaccinated, of course, 3 doses. At least I got it with my wife. She's a law professor, so we can spend more time now together in isolation. By the way, I'm now also sitting on the advisory committee on polio. We have circulating vaccine-derived polio now in Israel. It's a big issue, only because of Ukraine and pandemic fatigue. Some of you miss it, but it's very tricky. Those who remember what happened in Israel in 2013-14, this is even more complicated, but it's not our topic today, although it's a bit related. I join you for part of the day. I heard also Professor Collins. Unfortunately, then I needed to be in some meetings and the PhD exam. So thank you for having me. It's a fascinating topic, and I want to thank, of course, Ute and Sophie and all those who are involved. I'm always love to be in the center events. It's very refreshing. I have a degree also in history and philosophy of science. So having the option to have such a multidisciplinary and interdisciplinary dialogue is extremely important, and I'm very proud that it's taking place at Ben-Gurion University. Let me know if you see my presentation. I just moved to the beginning of it. Okay, is it now full screen?
No. Yes. Yes.
Okay, thank you. So, of course, it's a bit to maybe even the hubris of going from smallpox to COVID-19, now maybe even polio. But I many times share this frustration that, especially within the medical world, we are very preoccupied with evidence-based medicine. There was some discussion about meta-analysis and so forth. And for someone who is within the public health profession more than 2 decades, many times the issue of public health research and public health research ethics is not getting the similar attention comparing to clinical and biomedical scientific research. And also I think the discussion about causation within public health is something that is very different. So I'll bring you today some of my reflection that are both historical and sociological, also epistemological actually. And I hope this will be relevant for the overall discussion. But before starting this, I'm always bringing this slide because I always like to start with values when we're doing this kind of analysis. This is from 1892. It's the trendy pandemic was cholera, not influenza, of course, not yet COVID. And actually, cholera is important. If you remember, Robert Koch is a very important figure, and there is a Koch postulate that I'm not going to mention today, but interesting from the perspective of causation in biological and bacteriological studies. But actually, I brought this slide. It's a caricature from Judge 1892. You see, they come arm in arm. This is Asiatic cholera death. And you can see here Uncle Sam. It's written American ports close to immigrants from cholera-stricken countries. This is Europe. And here you can see how thin the line can be between this image of a poor immigrant. We have now also refugees from Ukraine and how thin is the line between one that can be a carrier of a disease, and this whole concept of being a disease carrier actually was discovered around these years, including the famous story about Typhoid Mary, if you remember. She was an Irish cook that was carrying Salmonella typhi and infected several occasions, and even people died because of it. And when there was an epidemiological investigation, they asked her to be in isolation, and every time she finally got back to her position, it was very hard for her to understand this whole concept of someone who is seems to be healthy, but she was a carrier of Salmonella typhi in the gallbladder. And finally, after she refused several times and continued to infecting people, she was taken in isolation for more than 2 decades. So all this issue about causation, it's not just a scientific question, it's also very practical. And also during COVID, we had the question about isolation and the question about humans that are carrying the disease. And again, how thin is the line between having a person who is a carrier and thinking about someone as the disease itself. And this is the anti-Semitic caricature, of course, of the Jew from the East, the Ostjuden, dirty, primitive. In the pre-Israeli era, the main kind of public health campaigns were among Jews from the East. Again, the Ostjuden, as they were described. Mainly, you had Jews from Germany, UK, France, with several societies such as OZE and TOZ, the Society for Preservation of Jewish Health. I have many posters and also movies about how they needed to educate the Jews from the East. Later on, after the establishment of Israel, you have the consolidation of the Ashkenazi Jew coming both from the East and the West. I guess that some of the Jews from Germany are not sleeping well in their graves when if they understood that they are lumped together with Jews from Poland. My family came from Poland, by the way. They were lumped together as Ashkenazi Jews, and the new Jews that needed to be so-called educated were those coming from Arab countries, the Sephardic or Mizrahi. So it's a very interesting concept how race and racism can be related to public health, and how flexible can be the issue of race. During COVID, I was also astonished to see how sometimes ultra-Orthodox Jews were called ticking bombs. I think that looking on human beings as ticking bombs, it's a kind of dehumanization. And it's, I think, very relevant to our discussion today about causation and what should be the framing of public health in this instance. Is public health about exclusion, about creating walls and doing quarantine, isolation, mainly to protect ourselves from others, whoever others can be, immigrants, poor people, etc.? Or is public health really about inclusion, not exclusion? And is it about human rights? And I think these two tendencies are always there throughout history. And I think that many times public health, unfortunately, is mainly being understood within a very militaristic kind of approach. I myself served as a physician in the military, in the IDF. I was trained as a public health physician in the Army Health Branch. Many of us turned to be key figures in the public health system, and including COVID-19 response. But although I was trained in the military, I think that many times, unfortunately, in Israel and other countries, it's very easy, so-called, to give responsibility to the military because we are not investing enough in the civilian sector. So it seems that I'm bringing different notions, but I think it's very important to start with these kind of values when we're talking about public health research and practice. And here, for example, you see the role of the military. And again, you cannot think about public health research and vaccination, by the way, without learning the historical aspects of public health research in the military, also among soldiers, among prisoners, but also lots of important advancements that were made. And you can see here, for example, quarantine on the border between Switzerland and Italy. You can see here the US public health services that until today are wearing uniforms, and many different measures such as fumigation, use of DDT. They tend to be many times very humiliating for some people, including here in Israel in the 50s. And you can see here the Canadian field hygiene section, the Laosing liberated Russian prisoners of war. And you have similar pictures also in the Israeli history. And that's something important to remember. Many that were fumigated the Laos not even remember it, but for many it was a very traumatic event. There is a Museum of History of Medicine that I really urge you to go and see across the road, where the Faculty of Health Sciences. The Israeli History of Public Health, it's on the 3rd floor. And if you have the time, I really urge you to go there and see. I myself studied quite a lot the history of ringworm irradiation, practice that was quite common up until the late 50s, including about 100,000 immigrants came to Israel, most of them from our countries. Many of them later suffered from different ailments, including head and neck cancer. And here also the question of causation became very important. There were studies, cohorts that were followed, and in the 70s, the Lancet published a paper, an article about head and neck cancer, higher risk among those irradiated. And of course, it's very anachronistic to claim that in the 50s when they were doing it, they knew about it. But I'm talking not just about cancer. There were children taking from the parents. These kind of measures were, by the way, mainly initiated by the Zionist and other organizations, a Jewish organization in Eastern Europe at the beginning. And that's something that is really interesting, and I can share with you several studies that I wrote about them. Until today, the compensation law that was enacted in '94, it's very interesting to understand what is the causation that is there. And in general, when you have legal trials, trying to connect exposure, different exposures can be infectious diseases, it can be environmental exposures to a certain outcome like cancer. That's something that is very, very hard sometimes to define. So Professor Collins, you mentioned physics and there were other papers talking about psychology. Within epidemiology and public health, many times you have multiple causations, and then it's very, very hard to understand exactly not only what is the biological and scientific causation, but how we can interpret it also to legal causation if you want to compensate maybe people that were exposed. So soon I will present you the Bradford-Hill criteria that are relevant, I think, for our discussion today, because some of the criteria is reproducibility. So it's interesting from a different point of view, and of course also the role of statistics that was mentioned today several times. And of course, many times also finally it's a human decision, to say, do we need a p-value below 0.05, or do we want a 0.01, or maybe in a legal context, just 51% probability is enough. And that's something that is very interesting. And I think it's going back to some of what Professor Collins discussed. I would like also to present the question of what is called sometimes social epidemiology, how maybe reaching into consensus is maybe much more important issue. And of course, this means that you need to be transparent and create rules for decision making. And maybe evidence-based medicine are not such good rules because they're too narrow. So today I would like to talk, for example, about evidence-informed decision making. That's something that we are doing an analysis. We established a new center at Ben-Gurion University of Implementation Science and Policy Engagement Center with Professor Moria Ellen. We're going to have an international seminar on the 9th and 10th of May. You are all invited. I'll give you later the details. And it's also about creating a consensus. So the question of irreproducibility or reproducibility, of course, is also related to the question of how you create a consensus and how you make, how you're doing the decision making. In my case, I'm very interested also from the move from science to policy making. And you cannot, of course, discuss today the question of policy making without understanding the sociological context. So many of us, and here on the left below, you can see I was compared to Dr. Mengele, not only myself, many other of my colleagues. It's here written in Hebrew that I have so much blood on my hands that with the vaccination we killed more than in any Israeli war and road accidents. Professor Dr. Sharon Alroy Price, the head of the Israeli Public Health Services, is now together with protection because there were so many threats on her. So how you can create a consensus and decision making and reproducibility when you have such a context, such a heated context of anti-vaxxers? Now, this is not new. Here, this is a caricature from 1916. It's from Life magazine. You can see these are anti-vaxxers at that time that are very angry with what they perceive as the medicalization of schools, and another discussion that is very common today. So you see, for them, the public school was turned into public clinic. Physical examination were made by Rockefeller Foundation, Public Health Service, health officer, keeper of the pound. It's also about what they described as being cruel to animals. So it's an anti-vivisectionist context. And of course, I'm very, very supportive of vaccination, but we need to remember that vaccination, although they are great, there were lots of criticism. Some of the criticism actually improved vaccination, like with the move from pertussis to acellular pertussis, and also medicalizing issues such as public health, obesity, and others. That's something that we need to remember, that public health, we have lots of power, but we need to be very careful. And this was true also when we enacted the lockdowns, and that's something that we need to also to remember. So I'm very proud of being a public health physician, but I think that sometimes we tend to forget that creating consensus and being transparent about science, that's something that is very important in order to create trust. And of course, trust must be made also remembering that vaccinations cannot solve all of our problems. If there are communities in Israel, for example, without access to water, like in some unrecognized Bedouin villages, I think it's easy to understand why they are suspicious about some public health measures, maybe because of fake news, of course, but also because they're asking, why you're just remembering us with vaccination, why not before? Are you afraid of being infected from us? And it's going back to the question of what is exactly the role of public health, exclusion or inclusion. So public health is much broader than medical aspects. So if physicians are usually stuck here on the, genetics, age, sex, of course, very important factor, and individual lifestyle factors, in public health, we take also the community context, living and working conditions, and you see that healthcare services are just probably influencing about 20% of our health. Of course, it's much more complicated than the interactions, but we cannot forget the socioeconomic, cultural, and environmental conditions. I'm very involved now with climate change and health, and also with health inequities as was presented in my research. So I think that if we talk about reproducibility and irreproducibility, we have here Bradford Hill causality criteria that were developed mainly during and after World War II, where let's say modern epidemiology was developed with discoveries such as the risk of smoking, something that was very, very controversial. That in the 30s and 40s, physicians were sometimes advertising cigarettes. There were other achievements in development of epidemiological methodology with observational studies, case control studies, cohort studies, clinical epidemiology. And you can see here, and I'm not going to go all over this table, the only necessary criteria is temporality, right? You cannot claim causality when something not preceding the outcome. But you can see here strength of association, consistency, okay? Consistency is about repeating the same results. Specificity, the gradient, plausibility, there should be a biological mechanism, a coherence, okay? So again, this is about reproducibility, experiment, okay? So if there are also experimental studies, not just observational studies, and also analogy, except from temporality, all the other criteria are not necessary, but are just giving more. But in many ways, like David Hume said, finally, even if there is temporality in all others, causation is something that is very, very problematic to prove, of course. But the Bradford Hill criteria is something that we are teaching, and students are being asked on that. Many times I'm using multiple choice questions, but of course this is very, very, we don't have now the time, but it's very important discussion. Okay, and the next level was to move, especially in the next 2 decades, after evidence-based medicine was developed. The term was first mentioned in, I think, in 1992 by a series of articles on JAMA. The whole perception was developed some decades before with clinical epidemiology. But you can see that evidence-based medicine, many times it's too narrow. And we want to bring evidence-informed decision-making by understanding that it's not just about scientific evidence. If I'm thinking that I'm going to the parliament, convincing the parliament to invest in public health measures, including vaccines, I'm doing now vaccines for brucellosis. We have a meeting tomorrow. It's not enough to bring just scientific evidence from the context of convincing decision-making. We need to understand the political context. We need to understand what are the resources available. We need to understand, yes, that we need to do lobbying, but there are going to be lobbyists from the other side, and also understanding of what community needs. So that's something that it must be taken into consideration, and that's something we are teaching our public health residents. Okay, and here you can see, again, if we start from the below, drivers for evidence-informed practice, okay, and we want to have a clinical thinker that is critical, and the health professional that is critical, okay, so we want to understand the role of evaluation and research awareness, application of knowledge, professional accountability. All of this must be taken also into consideration. And I think it's relevant for our discussion today, but it's bringing not just the philosophical or epistemological context, it's also the sociological and the policy. And I know that for some, this will maybe seem a bit dirty, but for a public health practitioner that want to promote public health, you must take it into consideration. And maybe to finalize, I think my time is almost over. I think that this means also that we need to have there is a clinical bioethics that was developed mainly after the Holocaust and the Second World War. It was mainly very individualistic with American influence. The role of autonomy was very important, and I think it's still important. But from when you deal with public health, and this is from Nancy Cass, an article published in the American Journal of Public Health, I think 2001 or 2002, just before they published their Code of Ethics, you can see that there is a framework of ethics analysis here specifically for public health is needed, because we start from a morally relevant different values that define clinical practice and research. Now, I don't think that these are contradictory. I think they are complementary, but I think that many times there are some tensions. And I have other slides. I will send it to you. I see that my time is running, but just to summarize, and maybe I'll skip to the last slide. If we want to speak about causation, for example, in public health, and to ask how pandemics end, and see, this is from Gina Colata, the New York Times correspondent, already in May 2020. And there are two quotes from close friends. Alan Brandt was one of my PhD advisor, and Dora Varga, historian of medicine from Exeter. And you can see an end can occur not because the disease has been vanquished, but because people grow tired of panic mode and learn to live with the disease. Many questions about the so-called end are determined not by medical and public health data, but by socio-political processes. Now, I'm not trying to diminish the role of epidemiology. I'm myself an epidemiologist, but I think that we need to be very humble, and I think all scientists need to be humble and understand that the question of knowledge and who's producing knowledge and how this knowledge should be finally being adapted and used is a much broader question. Dora Varga saying endings are very, very messy. Look back, we have a weak narrative for whom does the epidemic end and who gets to say. And I again want to go back to the first slide I show you with cholera. I think that we need to start from our values and ask, at least in public health, what is the role of public health? What is the relevant science there? How we can define causation, but finally, how this finally should inform our decision making. You saw that reproducibility is part of the Bradford Hill criteria, but I think that defining what is something that reproducible, especially in the age of so much rapid pace of publication and open access, that's something that need to have a very thorough discussion also about interest, who is publishing, the audience, and what are the interests of those doing the research, public money versus private money, and health inequities. Thank you very much.
Thank you very much. I think we have the time just for one or two very short questions. If someone has that. Or in the Zoom, among the Zoom participants, if someone has a question.
Can I ask a question? Yeah, okay, Professor Collins, I want to ask you later a question.
Yes, so please, Professor Collins.
You are muted. So I haven't got a question. I just wanted to make a statement. I don't think scientists want to be too humble. I mean, I think life has got much more complicated since 2016. You remember there was a new president elected in the United States who did things that none of us thought was possible since the 1930s. And I think if we want to save democracy, pluralist democracy, as I call it, I think we need to maintain our respect for science. Now, all the criticism of science over the years, including this reproducibility problem and so on and so forth, has reduced confidence in science, and we've got to find ways of getting it back. And I don't think the right way to get it back is to be humble. I think the right way to get it back is, to some extent, it was indicated by the last two chemistry talks. You know, one of the reasons that people need to respect science as an institution is because its bottom line is the truth, and therefore honesty and integrity. So as a kind of philosophically inclined sociologist, like other philosophers of science, I'm troubled by the demarcation problem. What's different about science? And the demarcation problem can no longer be solved by Karl Popper and some of the other formulas that people were putting forward in the 1950s. But I do think it can be solved by saying science is craftwork with integrity. And you keep stressing the integrity. It's different to nearly every other institution, because nearly every other institution in modern Western societies doesn't have the same kind of commitment to integrity. And I think that's one point at which scientists shouldn't be too humble. We need to be able to say, scientists need to be able to say, that is to say, epidemiologists need to be able to say, we know more about the power of vaccines than ordinary people, because we look at it from an institution which is committed to the truth.
Well, I agree, but I think we need to be very, very careful and balanced here to see, and here I think the role of history is important. I think that throughout history we saw that what you said, that again, I agree, that's something that we need to earn. It's not self-evident. Or there is something inherent also in science, the competition, sometimes maybe being detached too much from society and elitistic, that can create some hubris that can lead you to very, very horrible things. I take it to the extreme. German medicine just before the Second World War, this was the best science, and sometimes being too detached and being afraid of dealing with getting into consensus and understanding the context really can bring you into very dangerous positions. So I think yes, there is both. I'm talking now both about scientists and about physicians. Okay, it's not necessarily the same. There is some overlap, but not all physicians necessarily should be, amazing scientists, and some of them are very bad scientists, or think maybe they're excellent scientists. I think we need to be humble in a sense, maybe also towards other scientists, other disciplines, and understanding that maybe when I talk about causation in epidemiology, it might be quite different than a physicist talking about causation or psychologist. And here, I don't want to go to relativism, of course. So here, and this is a very long discussion, probably not now. I used to be very much, I'm talking maybe almost now 3 decades ago, within epistemological and positive logitivism and all of these demarcation questions. I became a bit, I felt that it's a bit sterile and not leading me anywhere. But I heard and learned a bit from my colleagues, especially at Bar-Ilan University, that there is a Science, Technology, and Society program, discussions about social epistemology, and some ways that are not so easy to find the right balance between not becoming a relativist, but on the other hand, being, yes, a little bit humble about how science progress and being critical and not falling into this kind of being authoritarian and not self-reflective. Because maybe another important part of science is developing a critical state of mind in a good way. I think not necessarily like Popper, but understanding the progress and the casting doubt and checking ourselves, but also being aware that there is a political context. I think it's important, but I don't think there is a one solution. I understand your point about Trump. So you cannot be too humble. I agree. but not being also too, naive about, being a scientist and understanding your role.
Thank you very much. I'm sorry that we have to stop here because we are running
Okay.
late. Thank you again very much.